Good morning. Good morning, ladies and gentlemen. This time, I came here to introduce a very special guest. This has been an everlasting question for all of us. What men live by and how will you measure your life if you can? In my humble idea, resilience. Doesn't matter how smart you are and how healthy you are, you need this. Without this resilience, you cannot create impact, which has value, and thus living a legacy is impossible. Back in 1989, horrible crash in Kelworth, and it terrified people. But there's one person who had a different idea, who looked very deep what has happened. And he proposed a very important brace position, which has a value to save our life. This has been an important brace position in all UK now. Can you imagine a surgery at 35,000 feet high in the middle of the air without nothing to help you? Yes, here's a man whose name is coat hanger surgeon. To be an innovative, creative person, what you need is diversity. Here is what your thinking is, but you need another plane of thinking. Then you can create various different creative things as like him. But he had all his purposes, and purpose is not a single moment purpose. It has been everlasting, enduring goal. Does he eventually have a legacy for us? In my simple mind, his equation is very simple, not as like the Einstein. His power is coming from all connectivity. What kind of connectivity? He got all these connections, important figures in a shoulder surgery, and eventually achieved a very, very important, successful meeting. Now, ladies and gentlemen, let's meet a person who's got resilient and has creative impact and has established a value and leaving us with a big legacy. Ladies and gentlemen, Angus Wallace with big hands.
It is a huge honor to be introduced by INHO to give this lecture. I would like to talk about our legacy to future patients, because we as surgeons are providing good care for today's patients, but we have to provide the best training for the next generation of shoulder and elbow surgeons. Many of you will wonder why a Scotsman has been working in England. I'm a missionary, and I moved to England in 1973 to educate the English. I have had to stay in England because they educate very slowly. But also, my wife, who is English, she has wanted to stay in England. She says the temperature in Scotland is too cold. At all these lectures, you have to declare your interests. My interest is a lifelong commitment to surgical training. And I have been involved with training in the UK and overseas in Hong Kong, Singapore, and China. And I do not have any other conflicting interests in relation to this lecture. This is the Codman lecture, and Ernest A. Codman, Amory Codman, wrote a book called The Shoulder, which was published in 1934. That book he printed himself. He had to pay the printer because there was no publisher who would publish it. This is a copy of the book. I don't have an original, but I am very proud of this book because it has an inscription from 1984 from Carter Row to Angus Wallace. May you interest in the shoulder extend to be extended by these pages. Now, Carter Row, I met at the first International Congress in 1980. He gave the first Codman lecture, and I am really proud to be here now. The book, although it focuses on disorders of the supraspinatus tendon, has 35 pages on hospital efficiency and the end result idea. And he was a controversial person, and if I can just read the top inscription: "Wonder if clinical truth is compatible with medical science. Could my clinical professors make a living without humbug?" So he was controversial, he was critical, and for those of you who would like to know more about him, not only should you look at the book, which has wonderful illustrations of the rotator cuff, partial and complete rotator cuff tears, but there has been a very good book written by Bill Mallon, currently the editor of the Journal of Shoulder and Elbow Surgery, on all about Codman, about his life, and how he went from being quite a powerful shoulder surgeon to being pushed into a penniless end of his career because he was so controversial. I am concerned that some of the things I say today might also push me in that direction. Surgical training in the UK in the 1970s, when I started, was influenced by this advice: see one, do one, teach one. And when I was a young surgeon in 1974, that was the way we learned surgery. See one, do one, teach one. That was not the best way to progress surgical training. And over the last 30 years, I have become deeply involved in surgical training, both in general orthopedics, in trauma, but also in healthcare informatics. And I was head in the UK and Ireland of orthopedic examinations for 3 years and orthopedic surgical training for 3 years. So the experience I'm going to tell you about is from the work that I've done in surgical training. We had to improve surgical training, particularly when arthroscopy came online in the 1980s. And in fact, the leaders in training at that time were James Esch and Steve Snyder. And James Esch began the San Diego shoulder arthroscopy meetings, and these meetings educated Americans about how they should carry out arthroscopy. In the picture, we see a very young Steve Snyder on the left and James Esch in the background. The picture quality is poor. We have come a long way since 1984. But there are 3 arthroscopic musketeers who have done a lot for arthroscopy in the US: Steve Burkhardt, James Esch, and Steve Snyder. And they have helped guide many surgeons towards improving their surgical skills. Steve Snyder set up his laboratory, which he called a classroom. And that classroom was where he trained surgeons in California in surgical techniques, arthroscopic surgical techniques, using something called ALEX. This was something that Steve Snyder developed with the Sawbones Company from 1989 onwards. But actually, our own Alex became a very good friend of Steve Snyder, and Alex Castagna visited Steve a lot and actually went under the knife under Steve with the first recorded pasta tear. And the Alex model is now called Alex the Shoulder Professor because of that friendship. In the UK, the person who forged the way in surgical training for the shoulder was Steve Copeland. His first shoulder course, held in 1984, was a fantastic thing to develop in the UK. He had realized that surgeons in the UK needed to understand more about the shoulder, and he set up a shoulder course held every 2 years, which allowed the average shoulder surgeon to come and learn about how to operate, how to manage shoulder problems. And I was very proud to be invited to the first course in 1984. Although Steve Snyder does not approve of cadaver courses, I do. And in 2002, I set up the skills workshop in Nottingham. And here we can see a cadaver course in Nottingham going on with some of the shoulder fellows that I've had. And in the bottom left-hand picture, you will recognize from this meeting one of my shoulder fellows, David Thiagarajan, who is in the audience. And we train on cadavers because that is the most lifelike way of training surgeons today. Companies have developed shoulder arthroscopy computer simulation, so you can actually do an arthroscopy without any instruments, but using a computer that makes you think that you are doing an operation. It is fascinating technology, and that is being brought in at the moment, but I'm not sure just how successful it is going to be long term. It's expensive, and I have struggled to get my shoulder fellows to use the kit that we have in Nottingham. And the cadaver workshops still seem to work better than using the computer simulation. Now, for the rest of my talk, you need to understand the training system in the UK that we have. To become a shoulder surgeon in the UK, you start off in medical school for 5 or 6 years. You start at age 18, you finish at age 23. You pass your final medical school examinations, and you then go and work in hospital as a foundation year doctor for general hospital training. You then go through a national selection process, you go through a process that takes you into core surgical training. You pass your MRCS examinations. You go into higher surgical training. You pass your fellowship examinations. So you are passing your fellowship examinations 11 years after medical school. It is a long training. So you already have surgical skills. And it is at that stage, 11 years after medical school, that you have a shoulder fellowship in order to develop your skills in shoulder surgery for becoming a consultant, a job that you will then be appointed to for a long time. In December 2000, we had a planning meeting in Wansbeck Hospital, which is in the north of England, where Paul Calvert, who was then head of orthopedic training, decided we would have a standard electronic logbook for our trainees. And Leicestershire, myself, Andrew Lamb, and Mike Reed built this electronic logbook. You can see the front page of the logbook on the web on the left-hand side. And this became compulsory for orthopedic trainees from October 2003. This was taken last week from the e-logbook page. That logbook now has 32 million operations on the database. That logbook is now being used by every surgical trainee in the UK and Ireland. And I was head of the team that introduced that logbook way back in 2003. One of the clever things that we did was we kept the information small, so there are only 3 pages. Top left, you put in patient details, but not the patient's name and not the patient's date of birth, because we are not allowed to identify patients in such detail. On the right-hand side, we have 2 drop-down lists for operations and for hospitals. So you click on the operation you've done, you click on the hospital, and then bottom left, you put in details that you might want to add about the operation and any complications. Very simple. The trick we did was that when the trainee filled out this logbook, the trainer automatically got this information put into his logbook. So he didn't have to do any work at all. And that has worked beautifully in the UK. We have published extensively on the electronic logbook, and we have learned a lot about orthopedic training as a result. We are now able to look at how trainees are trained in different training centres in the UK and Ireland. We're able to look at the different regions and work out how good the training is in different regions. We decided in 2010, when I was ahead of training, that we would identify 14 index operations. These are operations that every trainee had to do. They had to do a hip hemiarthroplasty 40 times. They had to do a compression hip screw 40 times. They had to do a hip replacement 40 times. These operations were chosen because in the UK, we train general orthopedic surgeons who at the end of their training can do general orthopedics and trauma and then specialize at the end of training. In 2016, we have now discarded palmar fasciectomy and lumbar discectomy because we do not have enough exposure to these 2 operations to expect trainees to do them. But we have now stipulated that every trainee in the country must attend 1,800 operations during their 6 years of higher surgical training. And this report demonstrates the situation with shoulder replacement. This is an analysis of shoulder replacement in England, in the north of England. And we have on the top histogram training from ST3 to ST6. That's the first 4 years of what we call higher surgical training. And the average trainee has a STS, that means he is a surgeon, and the trainer is scrubbed supervising him. The average trainee attends 1 shoulder replacement. That is never going to train them to be a shoulder surgeon. When we move to the last 2 years of surgical training and we look at the totals, the average number of shoulder replacements attended by trainees and carried out is 8 where they assisted and 4 where they were the surgeon. These are average figures. And remember that not all trainees will do specialist shoulder surgery. So that 4, when you look at individual trainees, if they have an interest in the shoulder, they will probably do about 12 during the year. This is an interesting analysis. This has come from David Large, who is currently head of training. And this shows arthroscopic subacromial decompression in the west of Scotland. And it shows the number of cases that the trainer carries out and the number of operations where he supervises the trainee. And you can see there is one particular trainer who does, over a 2-year period, more than 120 arthroscopic subacromial decompression. More than 120 arthroscopic decompressions, but trains almost no one. 20% of his operations he supervises. That is because he is a brand new consultant and he is developing his skills further. But the experienced consultants with high levels of operations may let 70% of their operations be carried out under supervision by their trainee. Things are changing. We are moving our training from experiential training, that is the training that has happened in the past, where you as a trainer operate in the OR and you have your trainee come and assist you and watch you and learn from watching you. That is no longer good enough. You have to actually train your trainee. You have to get him to do the operations, and you have to supervise him doing the operations. And that is essential for the future, and I know politically and financially that is very difficult in some countries, but it is our duty to train the next generation, and we have to find ways of doing it. And we now need to move on to competency-based training. That is training that allows a learner to demonstrate their ability, that we can watch their ability and watch them and tell them what training, what abilities they have, what they need to improve. And we are now changing towards competency-based training. So in the UK, when our trainees do an operation, we have to fill out a form afterwards saying exactly how the trainee carried out the operation, whether they carried it out satisfactorily or unsatisfactorily, and what bits of the operation they did well and what bits they did badly. And this is coming in across the world, although at the moment I believe the UK is an international leader in this. So here you can see from a procedure-based assessment, a PBA, does the surgeon, the trainee surgeon, deal calmly and effectively with unexpected events or complications? These are all sorts of questions that we have to answer as trainers. The PBA assessment is really important as part of our training program, and we've really got to make sure that our trainees understand when they are not developing their surgical skills properly. I believe the good qualities of a shoulder and elbow surgeon are that they have knowledge, they've read the books, they know about the surgical conditions, they know about the anatomy, and more importantly, they know about the natural history. Many surgeons believe that a tennis elbow must be operated on. If you wait 3 years, a tennis elbow gets better. You have to explain to your patient that a tennis elbow is a condition which eventually recovers, but you may be able to speed the recovery. You have to develop skills. And the most important skill is not the surgical skill, it's the examination skill. I am frustrated by how we have lost examination skills. And I remember I had 2 visiting fellows from Japan in my office looking at my patients as they came through, and I undressed the patients, examined them, and I chatted to the patients about their shoulder problem, and the Japanese fellow said, Professor Wallace, where's the scan? I said, what do you mean? Well, in Japan, we don't see patients until they've had an MRI scan. I said, well, in England, in the UK, we examine our patients first, and then we think about whether they need a scan. Surgical skills are really important, but becoming more important are communication skills. Your ability to communicate with your patient and make your patient aware of what you can give them, and more importantly, what you cannot do for them. You must have insight, and you must know what surgery can offer and what you can provide sensibly. And nowadays, we have to think about cost effectiveness of patient care, because we cannot bankrupt our countries by spending too much on patient care. And we only order a scan if it is going to change the surgical management of the patient. And I know from a comment from Tom just before I gave this lecture that in America you may get sued if you don't have an early scan, but in the UK we are more sensible. The qualities of a good shoulder and elbow trainer is that they must have knowledge of the different treatment options, and nowadays of the evidence base for the best operation for your patient. In other words, everybody in this room should be reading the Journal of Shoulder and Elbow Surgery, because that's where the evidence base is. The trainer needs to have good skills, and I would emphasize again examination skills, surgical skills, and communication skills are really becoming more and more important. It is no good, as my teachers in the past used to be, Mrs. Smith, you've got a painful shoulder. I will make it better. I will do an operation. You have to actually talk more to your patient, explain what operation, explain how successful that operation is likely to be. And you need to know your results, not the published results, so you need to be aware of what results you are getting. And nowadays, we need compassion. We need compassion to work with our patient because they are suffering. We are trying to help them through a difficult time in their lives. And cost containment. Your medical care has to be affordable. But probably most important, you need to develop as a trainer leadership skills, and you have to become inspirational for your trainees. Because I believe that even although we are moving more towards training which is supervised, we need to have trainees who are dedicated to learning. We need to have trainers who are dedicated to teaching. And I would encourage everyone here who is a specialist or consultant to take more time to teach their trainees than they have in the past. This new tool that has been developed has been developed particularly by two of my colleagues, Martin Holt and Duncan Tennant, who have developed something called OPAT, an Objective Practical Assessment Tool. And this allows them to assess a trainee doing an arthroscopy. So here is a recorded arthroscopy carried out by a trainee and not being done very well. They take this movie and they mark it according to how good they think the trainee is. Is the trainee demonstrating everything that they should demonstrate? Are they demonstrating the biceps? Are they showing the anterior edge of the glenoid? Are they using a hook to identify whether the glenoid labrum is damaged? Have they demonstrated the whole of the glenoid? Now, this trainee did not show us the subscapularis properly. We saw the top edge. The trainee is down in the inferior recess. We think he might be looking for loose bodies, but it's not a very good picture. He's trying to look at the posterior glenoid rim, but again, it's not the best picture in the world. There is some damage to the articular cartilage of the humeral head, which has early degeneration, and there is a small Hill-Sachs lesion as well as a bare area, but he wasn't sure which was a bare area and which was a Hill-Sachs lesion. So using this, you can actually mark your trainee and tell whether he is carrying out a good diagnostic arthroscopy or not. And then you go through a score sheet identifying how well he did that arthroscopy. Now, I have been fortunate in Nottingham in having over 30 shoulder fellows. Many are in the audience, and some of them may not entirely like what I'm about to say, because I have taken 10 of my trainees since 2004. Yeno and Basil, you're not in this, so don't worry. I have analyzed their logbooks to see how many operations they did under my care and how many they attended. And you can see that the average for all the trainees is about 200 operations over a period of 6 months that they attended. 30% they assisted the surgeon, which was either me or one of my other consultants, because usually the fellow is working with 2 consultants. In the third column, he was the surgeon, so the trainee was the surgeon, and he was supervised by me, and that applied to 30% of cases. But we have senior trainees who are like junior attendings, and 43% of the operations were done just by the shoulder fellow. And I accept that in other countries that might be difficult. But by looking at the logbooks, I can actually judge what the trainees were like. The trainee with the least numbers was a disaster. And I tried very hard to train that trainee, and I could not train that trainee. That trainee was with me for 6 months, and you will see that the number of assisted operations was almost 60%. And that was because the trainee started the operation trying to do it, and I had to take over. And they ended up assisting me. And at the end of the 6 months, that shoulder fellow was able to do some arthroscopic decompressions and very little else. However, if we look down at trainee number 9, who did 261 operations in our unit, you can see that he has carried out over 53% himself, and he would only get to do that if I had confidence in him. So I have now gone forwards and taken each logbook and looked at what they actually did for arthroscopic subacromial decompression. 6-month period, I'm able to analyze how many operations they did, assisted, and how many operations they did without assistance. And you can see that in the fellows that we had, 80% of arthroscopic subacromial decompressions were done by the fellow. Again, if you look at the weak trainees, and the top trainee here has done very few by themselves, but we did eventually achieve the near impossible. I also looked at rotator cuff repair, and the number of cuff repairs that our trainees did was less. And we're looking at the bottom here at an average of 4 where they were supervised and 12 where they were not supervised in 6 months. We looked also at acromioclavicular joint surgery. We also looked at surgical stabilization. And you will see here that there is one trainee marked as arrogant. That trainee came onto our unit wanting to be a consultant, a specialist, and believing he was totally, fully trained. He had no interest in coming and watching my operations. He just wanted to operate. And I've put these trainees in different colors. Red means that they're going to get into serious trouble later in life. Yellow means I suspect they're going to have some problems. And green means they've left my unit, I have full confidence in them, and they are going to be great surgeons in the future. And one is going to be particularly outstanding. I have to point out that that does not include 2 other outstanding fellows that I've had in the past, Basil Vretos and Yeno Kish, who were both outstanding and both went on to lead shoulder surgery in their country. If we look at shoulder replacement, what I was commenting on about the arrogant trainee, he landed up here only coming to 4 operations with me, only coming to 8 operations with me and went off and did 23 himself. Yes, he believed he could do shoulder replacement, but he could have learned so much from spending more time with me. The problem we had was getting enough experience for elbows, because elbow surgery is not done so much. We looked at tennis and golfer's elbow, and during 6 months, our trainees did approximately 4 tennis or golfer elbows release. So I'm now able to work out a list of shoulder and elbow index procedures that our unit can deliver to a trainee coming to work with us. If you come and work in Nottingham with us as a fellow, you will go away from our unit after a 6-month period having done 30 arthroscopic SADs, 10 rotator cuff repairs, 10 AC joint operations, 10 shoulder stabilizations, 10 shoulder replacements, and 5 tennis elbow or golfer's release operations. You will not get trained in elbow replacement surgery because there are not enough of them anymore. And I believe that we have to change our training to move in that direction. We cannot simply have trainees come and observe and send them off into the wilderness not properly able to operate. I'm really proud of the fellows who have come and worked with me in Nottingham. They have gone off and done great things in their own countries, and I'm very honored to be here talking to you about surgical training, which I am a great advocate of. I'd now like to move on and talk about my dear friend, Steve Copeland. Master shoulder surgeon, teacher, international shoulder leader, and Steve was invited to give this lecture, and I am giving this lecture in his place. His early career was as a junior surgeon, a senior registrar, on a London rotation, Barts and Percival Pott. On that rotation, you rotate to Norwich, which is in the east of England, and there he worked with a surgeon who had been doing scapulothoracic fusion for muscular dystrophy. Very unusual operation, and Steve took the opportunity of looking at the results of his operations by bringing back every patient and looking at the results. He then published the results in the Journal of Bone and Joint Surgery, but only after he had won top prize for research with that piece of research. That paper, written by Steve Copeland, remains a landmark paper. He was a disciple of Professor Lippmann Kessel in London, who set up the first International Shoulder Congress. He was appointed a consultant trauma and orthopedic surgeon with an interest in pediatric surgery to the Royal Berkshire Hospital in Reading in 1979 at the age of 33. For the young surgeons in the audience, his hospital contract was a 24/7 contract. Let me just explain that. He was contracted 24 hours a day, 7 days a week, 48 weeks a year to look after the people of West Berkshire. He had no time off. That was the way surgeons used to work in the past. 33 was a young age to be appointed a consultant. You were usually appointed at 36, so he was obviously bright. He was selected as one of the top orthopedic surgeons in the UK by the British Orthopedic Association and became an ABC travelling fellow in 1982. And then he started the Reading shoulder courses in 1984, but he did not move into full-time shoulder surgery until 1994. Now, this is a rare picture in 1983. If you look at that picture, that was when I visited Dr. Neer in 1983 at Columbia Presbyterian Hospital. And it is a rare picture because if you look at Dr. Neer's face, he has a slight smile. Dr. Neer rarely smiled at that time. And the reason he was smiling was I had parked my Winnebago, a motorhome, in the Columbia Presbyterian car park, and I had occupied 6 places that were supposed to be used for cars, and Dr. Neer got into trouble from the hospital management. That's what he's smiling about. This is the first Reading shoulder course, the program, 1984. Charles Neer, invited guest lecturer. Lippy Kessel, Ian Bailey, myself, and Steve Copeland, and some others. And I joined Steve the evening before the course. Jenny, his wife, wonderful hostess. We always had a faculty dinner the night before. And if you look at the picture, I'm sorry they're poor photos, but on the left is Lippy Kessel, and on the right is Lippy Kessel and Dr. Neer. Now, the body language tells it all. There is no eye contact. They would not look at each other. And when Steve was entertaining them in his home for the dinner before the conference, He placed Dr. Neer at one end. He placed Lippy Kessel at the other end of the table. And he spent the whole evening very diplomatically going to speak to one and then going to speak to the other and making sure that everybody was happy. But neither spoke to each other during the whole dinner. The second shoulder course in 1986 was again highlighted by Dr. Neer being a guest lecturer, and here is a photograph from that with the top British shoulder surgeons at the time: Chris Constant, Ian Bailey, Mike Watson, Rolf Birch, Ian Kelly, myself, and in the front row, Charles Neer and Steve. In 1987, we had a Harley Street meeting, and Michael Watson, second from the left, invited us all to Harley Street to talk about setting up the British Shoulder and Elbow Society meeting. Now note, it was British Shoulder and Elbow Society when we discussed it, but it later became BES. I became very friendly with Steve, and Steve asked me to carry out some pull-out tests on his Copeland glenoid component that he was developing with fins. He was developing this with Zimmer, and I said to Steve, "Steve, this is idiotic. Why are we doing a pull-out test on a glenoid when the glenoid is always under compression during use of the shoulder?" Steve said, "I'm doing it because Zimmer wants it done." I said, "Okay, I'll do it," and we did it in my laboratories in Nottingham. Little was I to know that 30 years later, we have a poster at this symposium showing that the vacuum forces in a total shoulder replacement are so high that they could pull out the glenoid. So we learn every year. And this is us at our planning meeting having lunch, courtesy of, at that stage, Michael, because Michael was earning most money in Harley Street at the time, Michael Watson. Steve was a fantastic lecturer, fantastic teacher, and an example of exactly how popular he was is highlighted by 2 years of invited guest lecturers from 1999 and 2000. And these are the lectures he gave in Los Angeles, London, Corboda, Brussels, The Hague, Canada, and Paris. Wonderful teacher. He was president of BES, president of CESEC, secretary of the IBSES, chair, or what I think should be called president of IBSES, and on the organizing committee of ICSES. He served you all for many years. But he was a special friend for Jackie and myself. And here we see a picture of Jenny, Steve, and Jackie taken from 2000 when we were in Paris. We had interesting travels. You will note this obelisk on the right. It reminded me of a bit of anatomy. I'm not allowed to say which bit of anatomy, but when I mentioned it, Jenny laughed. And we had great fun together. Here we are at CESEC in Lisbon, the three wise monkeys. See no evil, speak no evil, hear no evil. And this is a lovely photo. It's not good quality. It was taken in Washington, D.C. in May 2004 when we won the competition to get the International Congress to Edinburgh. Herbert Resch, Ian Kelly, Sergio Cecchia, Steve Copeland, and in the front, Lou Bigliani and Neer. And it's a lovely photo because it reminds us of both Ian Kelly, who put up the bid for Edinburgh with me but died shortly after this photo, and Steve. We visited America, Florida, just after Hurricane Katrina. What terrible devastation that left. And here we are at the International Congress in Edinburgh in September 2010, that should be. And we missed out Ian Bailey. He wasn't there, but I have put him in, not very cleverly. But these are all the presidents of the British Elbowing Society. Steve and I have both been presidents, and it was a great honor for us to do that work. Personally, we've been friends, and Steve and Jenny came up and spent time with us in Gleneagles. I remember this particular dinner very well, because I actually collapsed at the end of this dinner. Jackie's cousin, Bill, ordered the wine. It was the most expensive wine on the menu. Andrew Fairley's is a Michelin 3-star, 2-star, 3-star restaurant. I had a bill at the end of that meal for £1,200. I've never had a bill like that before. And I collapsed, and it was all Bill's fault. Steve and Jenny were very, very considerate and helped me pay it, but it was quite a difficult time. And here is a lovely picture, because here is Steve and Jenny and Hiroko Fukuda when we were in Japan 3 years ago. And it's lovely that she is here to join us today. Hiroko, we have been friends for many years. Thank you for coming. And this was Steve's final duty. He had to examine a thesis in Dundee. And he did this in 2014 when he was very ill, and he still felt that he had to do this work for the student in Dundee who was being examined. And it was difficult for him, but we really appreciated that he did it. This is Steve and Jenny when Steve was well, and looking so well, and enjoying themselves in another expensive restaurant in Lyon. Steve was a family man, and it's really important for you to understand that his children, Sarah and Matthew in the back row, and all their children, miss him. He looked after them with Jenny very well. He was a master shoulder surgeon. He was a real gentleman, a great teacher, a leader, and a lovely father. Thank you.
Thank you. Thank you, Professor Wallace. In the letter of appreciation, we present a letter of appreciation to Professor Wallace. The title, Our Legacy to Future Patients, the Best Training for the Next Generation of Shoulder and Elbow Surgeons, a celebration of Steve Copeland, a past president of ICSES, a charismatic surgeon and a gentleman, May 18th, 2016. On behalf of 13th ICSS Organizing Committee, we would like to express our deepest gratitude for your outstanding contribution to the Congress. Thank you. Thank you, Professor Wallace and Professor John, for all your effort.